All right, so this chapter is gonna look at patients who have chronic disabilities, patients with chronic medical problems, and patients, hold on, patients who have to rely on devices or specialized equipment to function in their everyday life. Come on. All right. Introduction. Today, more people with chronic diseases live at home, and that is due to shorter hospitalization times and improvement in medicine and technology. Patients with special challenges. These are patients with diseases resulting in altered body function, patients with sensory deficits, geriatric patients with chronic diseases. Some patients depend on mechanical ventilation devices, intravenous pumps, and other devices. Do not be distracted by the equipment. Always focus on your patient. Intellectual disability. This is developmental disability. Conditions that may impair development with physical ability, learning, language development, or behavioral coping skills. Intellectual disability is a subset of developmental disability. Significant limitations in intellectual functioning and skills needed for daily living. So they have limitations because of their intellectual development, and it affects how they function in their everyday life. Now, possible causes: genetic factors, congenital infections, malnutrition, environmental factors, fetal alcohol syndrome, traumatic brain injury, poisoning. With these patients, you need to rely on the patient and family members for information. So these patients are well informed regarding their condition if they can communicate and give you information regarding their disability. That will be valuable info. And family members will also be able to guide you, especially if they have been around them for an extended period of time. Patient may have difficulty adjusting to change or a break in routine. Patients with intellectual disabilities are susceptible to the same diseases as other patients. Now, first one we're going to look at is autism spectrum disorder. Intellectual disability characterized by deficits in social communication, along with restrictive, repetitive patterns of behavior and interests and activities. Often have abnormal sensory responses. They may not feel cold, might not feel hot, they might not feel pain the way other people do. They may respond to pain by laughing, humming, singing, or removing clothing. They may have increased sensitivity to noise or physical stimulation. So you have to be very careful how you manipulate things in their environment and how you make contact with these patients. Increased sensitivity to noise or physical stimulation. Demonstration of examination techniques on a trusted individual may comfort the patient. So demonstrate what it is that you're going to do before you do it. Use short, direct, and simple phrases when communicating. Allow extra time for the patient to process the communication if possible. Down syndrome, also known as trisomy 21, because of the extra chromosome on the 21st pair. A genetic chromosomal defect that can occur during fetal development. It results in mild to severe intellectual impairment. It increased maternal age, and family history are known risk factors. Now, physical abnormalities with patients with Down syndrome. They have a round head, they have a flat occiput, they have an enlarged protruding tongue, slanted, wide-set eyes. They are at a increased risk for medical complications. Some of these would include leukemia, congenital heart defects. Because of the abnormalities with the tongue, their airway can be easily obstructed, and it might be very challenging to manage their airway effectively. So intubation may be difficult due to large tongues and small oral and nasal cavities. Mass ventilation can be challenging. Jaw thrust maneuver or nasopharyngeal airway may be necessary. Management of seizures is the same for any other patient. Allantoaxial joint is unstable in approximately 15% of patients with Down syndrome. Increased risk of complication when they experience trauma. Patient interaction. So when approaching a patient with Down syndrome, approach in a calm manner, be very friendly, establish rapport, introduce your team members, explain what you're doing, move slowly but deliberately, stay at eye level with the patient. Brain injury. Patients with brain injuries now. Patients with a prior brain injury may be difficult to treat. Talk with the patient and family. Establish what is considered normal for the patient. Explain procedures and reassure the patient. Patients with visual impairment. Possible causes: congenital defect, disease, injury, degeneration of the eyeball, optic nerve, or nerve pathway. Range in degree of visual impairment. Some patients lose their peripheral or central vision. Some can distinguish light from dark or shapes. Visual impairments may be difficult to recognize. This is how you will interact with these patients. So, interaction with patients with visual impairment. Make yourself known when you enter. Introduce yourself and your team. Retrieve any visual aids and give them to your patient. Patient may feel vulnerable and disoriented. Describe the situation and surroundings to the patient. And remember, if you move things around in their environment, you have to put it back because they are accustomed to navigating their environment based on where certain things are located in their personal space or environment. Transport consideration. Take cane or walker if used. Make arrangements for care or accompaniment of service animals. Sometimes they have a service dog. Patient should be gently guided, never pulled or push. Communicate obstacles in advance. Patients with hearing impairment. Problems range from slight hearing loss to total deafness. Many older people have some hearing loss. Sensory neural deafness is caused by nerve damage. Conductive hearing loss is caused by faulty transmission of sound waves. Clues that a person could be hearing impaired: the presence of hearing aids in their environment, poor pronunciation of words, failure to respond to your presence or questions. Communication with hearing impaired patient. Assist the patient with finding and inserting any hearing aids. Face the patient while you communicate. Do not exaggerate your lip movements or look away. Position yourself approximately 18 inches directly in front of patient. Do not speak louder. Try lowering the pitch of your voice. It would be useful if you know sign language to communicate with these patients. Provide paper and pencil. Only one person. Ask questions. Reverse stethoscope method might be beneficial. And what they mean is you would put the earpiece in the patient's ears and you talk in the diaphragm of the stethoscope. Some simple sign language. Sick, hurt, help. Can look at that when you have time. Hearing aids. Hearing aids make sounds sound louder. Maybe external or internal. Several types are available. Behind the ear, conventional body, in the canal, in the ear. Device should fit snugly. If whistling occurs, it may not be in far enough. And this is these are pictures depicting the different types of hearing aids. Cerebral palsy. This is a group of disorders characterized by poor controlled body movement. And there are numerous things that can cause that. Possible causes: brain damage in utero, oxygen deprivation at birth, traumatic brain injury, infections such as meningitis during early childhood. Symptoms: poor posture, uncontrolled spastic movements, visual hearing impairments, difficulty communicating, unsteady gait, and they can have paralysis. Whether it's the upper ear body or lower body or all four limbs, they can have paralysis. Considerations: observe airway closely and suction as needed. Do not assume intellectual disability. Underdeveloped limbs are prone to injury. Ataxic or unsteady gait makes the patient prone to falls. Patients may have special pillow or chair. Pad the patient to ensure comfort. Never force extremities into position. Whenever possible, take walkers or wheelchairs along during transport. Be prepared for a seizure and keep suctioning available. Spina Bifida. It's a birth defect caused by incomplete closure of the spinal column. The cord is exposed. Opening can be closed surgically, but often leaves spinal damage. Associated conditions: they can have hydrocephalus, that's too much fluid in the cranium, and these patients will require a ventricular shunt. So they'll have a tube running from their head to and it runs down to the abdomen to empty that fluid outside the body. Partial or full paralysis of the lower extremities might be present. They may have loss of bowel and bladder control, and they have extreme allergies to latex. Paralysis: inability to voluntarily move body parts. Causes: can be stroke, can be trauma, it can be a birth defect. May have normal sensation and Hyperesthesia or esthesia may cause communication challenges. They may have issues with their diaphragm, so their diaphragm may not function correctly, and this can lead to ventilation complications. Specialized equipment. They may have urinary catheters, tracheostomy tubes, colostomy bags, feeding tubes. They may have difficulty swallowing, and their airway may require suctioning. Ask patients how it is best to move them before you transport. Bariatric patients. Obesity. Person has excessive body fat. Obese 30% over ideal body weight, and there's a formula to work out ideal body weight. Severe obesity, 2 to 3 times over the ideal body weight. Imbalance between calories consumed and calories used. They may have that. May be attributed to low metabolic rate or genetic predisposition. Their persons who are obese, their quality of life is negatively affected, and they can develop a lot of health problems. They may have difficulty moving around. They can develop diabetes, hypertension, heart disease. They're at risk for stroke, a lot of complications. Interactions with patients with obesity. Patient may be embarrassed. Plan early for extra help or equipment. Find the easiest and safest exit. Do not risk dropping the patient or injuring a team member. So make sure that your team members can manage the weight of the patient. And if they cannot, wait until enough persons are present for you to move the patient. Treat the patient with dignity and respect. Ask your patient how it is best to move him or her before attempting to do so. Avoid trying to lift the patient by one limb. It's not going to happen, which would risk injury to overtaxed joints. Coordinate and communicate all moves to all team members prior to starting to lift. If the move becomes uncontrolled, at any point, stop, reposition, and resume. Look for pinch or pressure points from equipment. These patients may have deep vein thrombosis, which can be life-threatening if that clot dislodges. Large patients may have difficulty breathing if you lay them in a supine position. That's something you need to think about if it's a patient that you need to breathe for with a BVM, so they can't stay completely flat. So you may have to get them on that stretcher and elevate the upper portion of the stretcher. Continue with interactions with patients with obesity. Again, specialized equipment, if needed, request it. Become familiar with the resources available in your area, plan egress routes, notify the receiving facility early. Patients with tracheostomy tubes. Tracheostoma provides a path between the neck and the trachea, kept open by plastic tracheostomy tube. Tube bypass nose and mouth. It can be temporary or it can be permanent. For patients who depend on home automatic ventilators and have pulmonary illness, these are the patients you will see with these type of devices. Tubes are prone to obstruction by mucus or foreign bodies. The most common issue is going to be mucus production or a mucus plug. And if you're going to suction a tracheostomy or tracheostomy tube, it must be a flexible suction catheter and it must be a sterile technique. You have to use sterile gloves. When you have on sterile gloves, your hands must never go below your waist. Use the DOPE mnemonic. This helps to recognize causes of obstruction, which include displacement, dislodged or damaged tube, obstruction of the tube, pneumothorax, equipment failure. Common problems include bleeding or air leaking around the tube. Tube can become loose or dislodged. Opening around the tube may become infected. Management: maintain an open airway, suction tube if necessary to clear a mucus plug, must be a sterile technique. Maintain the patient in a position of comfort, administer supplemental oxygen, provide transport to the hospital. Humidified oxygen. Home oxygen, patients with home oxygen. Two types of oxygen delivery devices: oxygen from a gas cylinder or oxygen concentrator. Compressed oxygen cylinders do not require oxygen or complex machinery. They are heavy, bulky, and can be difficult to transport, will run out of gas. Patients coordinate pickup and delivery of these cylinders. The home oxygen concentrator. It takes ambient air and scrubs out the nitrogen so the patient gets pure oxygen. Can provide an unlimited supply of oxygen, requires a reliable source of electricity. Patient must have a backup compressed gas cylinder in case of power failure. Ask the patient why they are on home oxygen, very important question. How long they have been on home oxygen, baseline home oxygen requirement, baseline oxygen saturation. All of these things are important. Mechanical ventilators. Used when patients cannot breathe without assistance. Possible causes of that would be congenital defect, chronic lung disease, traumatic brain injury, muscular dystrophy. If the ventilator malfunctions, remove patient from the ventilator, apply a tracheostomy collar designed to cover the tracheostomy hole, may not be available in the pre-hospital setting, can improvise by placing a mask over the stoma. That's what a home ventilator looks like. Caregivers will know how the equipment work. Let them guide you. Apnea monitors. Apnea monitors are used for infants who are premature and have severe gastroesophageal reflux or GERD. They have family history of SIDS, experience a life-threatening event. Use 2 weeks to 2 months after birth to monitor the respiratory system. Sounds an alarm if the infant experiences bradycardia or apnea, both of which would be bad for the infant. Attached with electrodes or belt around the infant's chest or stomach, provides a pulse oximetry reading. Internal cardiac pacemakers. These are implanted under the skin to regulate the heart rate. On the non-dominant side of the patient. It may include an automated implanted defibrillator. Never place defibrillator paddles or pacing patches directly over an implanted device. That's a no-no. Gather information about the type of cardiac pacemaker when obtaining history, if possible. Left ventricular assist device. I spoke about this particular device when we covered cardiovascular emergencies. I just couldn't remember the name. So it takes over the function of either one or both heart ventricles, typically used as a bridge to heart transplantation. So it's a device that they use while they are trying to find a donor. It may be difficult to palpate a pulse, or you might not feel a pulse any at all. Provide supportive measures and basic care. Use the caregiver as a resource. They can, once they are communicating, they can tell you everything about the device. Be prepared to provide CPR. External defibrillator vests. Vests with built-in monitoring electrodes and defibrillation pads worn by patient under his or her clothing, attached to a monitor that provides alerts and delivers a shock. And only 2 rhythms can be defibrillated: pulseless ventricular tachycardia or ventricular fibrillation. These are the 2 rhythms that are defibrillated. If patient is in cardiac arrest, vest should remain in place while you perform CPR. Central venous catheter. This is a catheter with its tip placed in the vena cava to provide venous access. Used for many types of home care patients. The common locations for this device is the chest, upper arm, subclavicular area. Common problems: the line can break. They are prone to infections around the line. They can develop clots around the lines, bleeding around the line or from the tubing attached to the line can also occur. Gastrostomy tubes. These are placed in the stomach for patients who cannot ingest fluids, food, or medication by mouth. May be inserted through the nose or mouth into the stomach. May be placed surgically directly into the stomach through the abdominal wall. These tubes may become dislodged. Once that occurs, immediately stop the flow of any fluids. Assess for signs or symptoms of bleeding into the stomach. These patients will have vague abdominal discomfort, nausea, vomiting, and it usually have a coffee ground color. Blood in the emesis may be present. They are at an increased risk for aspiration. Always have suction readily available. Patients with difficulty breathing should be transported while sitting or lying on their right side with the head elevated 30 degrees. Continue tube feeding unless the tube is dysfunctional, dislodged, or partially dislodged. Shunts. Shunts are for patients with chronic neurologic conditions. These are tubes that drain excess cerebrospinal fluid, and they have a fluid reservoir. Device beneath the skin on the side of the head behind the ear should alert you to the presence of a shunt. You have different types of shunt. You have ventricular peritoneum shunt, and you have the ventricular atrium shunt. It can be blocked or infected. Shunt may cause changes in mental status and respiratory arrest if it is blocked or infected. Infection may occur within 2 months of insertion. Signs of distress that you need to look for: high-pitched cry or bulging fontanelles that suggest hydrocephalus, headache, projectile vomiting, altered mental status, irritability, fever, nausea. Difficulty with coordination when walking, blurred vision, seizures, redness along the shunt track, bradycardia, heart dysrhythmias. Vagus nerve stimulators, and you'll see this more in the pediatric population. It's a device that stimulates the vagus nerve to slow down brain activity and help to reduce seizures. So it's treatment for seizures, not controlled with medication. It's surgically implanted. It stimulates the vagus nerve to prevent seizure activity. It's used in children older than 12 years. So it's specifically for the pediatric population. Located under the patient's skin, about the size of a silver dollar. If you encounter a patient with this device, contact medical control or follow your local protocols. Colostomies, ileostomies, and urostomies, sorry. Colostomy and ileostomy. Procedure that creates opening between the small or large intestine and the surface of the body. It allows the elimination of waste products into a clear external bag or pouch, which needs to be emptied or changed frequently. Assess these patients for dehydration if the patient has been complaining of diarrhea or vomiting. The area around the stoma is prone to infection. Signs of infection that you need to look for: redness, warm skin around the stoma, tenderness over the colostomy or ileostomy site. Urostomy. Urostomy is a surgical procedure that connects the urinary system to the surface of the skin. It allows urine to drain through a stoma in the abdominal wall. Contact medical control or follow local protocols for care of a patient with a colostomy, ileostomy, or urostomy bag. Now, the patient assessment guidelines that we need to follow for these patients with special challenges. Interaction with caregiver is an important part of the patient assessment process. They are experts on caring for these patients. Determine the patient's normal baseline status. So you need to know what is considered normal for these patients before you start your assessment. Ask what is different today. Home care. This occurs within home environment. It represents a spectrum of the population, which include infants, older adults, patients with chronic illnesses, developmental disabilities, service delivering meals, cleaning, laundry, maintenance, physical therapy, and personal care. These patients will need all of that. EMS may be called to residents by home care provider, obtain baseline health status and history from home care provider. Hospice care and terminally ill patients. Terminally ill may receive hospice care at a hospice facility or at a home. Most may have a DNR order, and you need to know what type of DNR order it is, because you have different types, and there are some things that you need to look for on the DNR order. May have a medical orders for scope of treatment. Comfort care. These patients will require comfort care, palliative care, pain medication, improves quality of life before patient dies. So the palliative care is necessary for that. Follow local protocol, patient's wishes, legal documents. Bring documentation to the hospital, show compassion, understanding, and sensitivity. Ascertain the family's wishes regarding transport, allow family members to accompany the patient, follow local protocols for handling the death of a patient. Poverty and homelessness. These patients are unable to provide for basic needs. They're not in a position to meet their basic needs. Disease prevention strategies are absent, and it puts them at risk for increased probability to acquire chronic illnesses or diseases. The homeless population includes patients with mental illness or prior brain trauma, domestic violence victims, addicts, impoverished families. Advocate for all patients. All healthcare facilities must provide assessment and treatment regardless of the patient's ability to pay. Become familiar with social services resources within your community. And that would bring us to the end of this chapter.